Hi, everyone, and welcome back. This is the Insights podcast. As a reminder, Insights is a um, podcast that is based on the wonderful content that's available on Call. And On Call is a continually edited um, online textbook that's produced by leaders in neurocritical care and is available at neurocriticalcare.org. We really invite you to check it out. These are meant to be short conversations that highlight some of the important and the most critical things you need to know to manage these patients at the bedside. But the chapters are really in depth and they have wonderful tables and charts, and we invite you to check them out. As a reminder, this podcast is sponsored by Biogen and Cerebell, and we are so grateful for this week's sponsor.
Founded in 1978, Biogen is a leading global biotechnology company that has pioneered multiple breakthrough innovations, including a broad portfolio of medicines to treat multiple sclerosis, the first approved treatment for spinal muscular atrophy, and two co-developed treatments to address a defining pathology of Alzheimer's disease. Biogen is advancing a pipeline of potential novel therapies across neurology, neuropsychiatry, specialized immunology, and rare diseases, and remains acutely focused on its purpose of serving humanity through science while advancing a healthier, more sustainable, and equitable world.
All right. Hi, JC. How are you?
Good. It's good to be back.
Awesome. Yes. So today we're going to talk about meningitis and the encephalitis. As we kind of talked about this even in the chapter, these disease states are not really that common, although I feel like in our unit we label everyone with meningitis and we try to see if this is something we can rule out. But I wanted to ask you how you typically assess these patients. How do you define these disease states? And when do you usually suspect that these patients may have meningitis or encephalitis?
Yeah, it's a great question. I think in general, these are to really be diagnosed with meningitis or encephalitis. It's actually a rare condition, but it is extremely devastating if it is missed. And I think our patient population within neurocritical care is really enriched in these patients because we take care of patients who've got, open access to the CSF, whether they've got trauma or they've had recent postoperative cases. And so that, really enriches our patient population. Um, but I think it's also really important to kind of step back and recognize that, a lot of times when we're thinking about meningitis and encephalitis, we're really talking about infectious meningitis and encephalitis. But meningitis technically is just inflammation of the meninges. And that can happen from a lot of different etiologies. And so I think, the conversation we're going to have here today is about infectious etiologies and a lot of that, acute management. But I really want to emphasize that, a patient with a headache and evidence of CNS inflammation, they may have an autoimmune, they may have a systemic cause, they may have leptomeningeal carcinomatosis. So just evidence of inflammation of the meninges does not mean that it is infectious. And so I think we really, really have to keep a broad differential. So again, terminology is important, and we should also, make sure that we're really screening the drug list because chemical meningitis, such as one might see with a subarachnoid hemorrhage and that blood causing irritation, or even with a medication like IVIG, all of those are reasons that a patient may have a really severe headache and evidence of inflammation in the CSF that has nothing to do with an infectious etiology. So let's drill down, though, in terms of thinking about infectious etiologies of meningitis, and we'll start with meningitis. The way that I really like to kind of categorize this is by thinking about the host risk factors. When we think about who's going to get meningitis, it's really important to consider, is this patient immunocompromised? Do they have advanced HIV? Do they have, cancer for which they're on really immunosuppressing chemotherapy? Are they on chemotherapy for some other autoimmune condition? Because that's going to really kind of change what etiologies you're thinking of. And I certainly think, especially with our advanced HIV patient population, really making sure that we exonerate cryptococcal meningitis, because that is of etiologies of meningitis is one of the more common in an immunosuppressed population. I also try to think about where does the patient live because that really determines their exposures. When we think about um, types of meningitis, there certainly are regional variability on what infectious etiologies are prevalent in what part of the country. And then the time of the year. So, summertime is where we see an uptick in both meningitis and encephalitis based on just arbovirus transmission. So a lot of these etiologies are caused by arboviruses. And so it's really important when we're thinking about, you know, what is this patient likely to have infectious meningitis? That if it's the summertime and you live in an area where there are a lot of mosquitoes or ticks, then we have to think about, tick-borne or mosquito-borne etiologies. And then really, this definitely depends on analysis of the CSF. And so, meningitis, I really think you have to prove that there is inflammation in the CNS space. So, when we think about certain kind of autoimmune encephalitis, you might actually see sort of a normal CSF, but within our meningitis patient population, you really normally should see inflammation. Um, and so this condition, when you are evaluating a patient at the bedside, the classic, symptoms are going to be that really severe headache and fever for the infectious etiologies, and then nuchal rigidity. And we think about certain signs, but I actually don't even like those signs because I don't think they're very sensitive. And what I clue into is that really extreme headache because the meninges are innervated, and so they're very sensitive. Um, so once we have that suspicion, then I think it is really imperative that we get CSF sampling, not only to know what the etiology is, but to hopefully at some point be able to kind of direct our antibiotic course. One of the things that often comes up is going to be who needs a CT before they get an LP. And the data around this is actually quite poor. And so I wish we could say we have really robust studies that show us who needs this, and it's really well validated. And that is unfortunately not the case. Um, the people who we know, certainly the immunocompromised patient, any patient with altered mental status. I mean, at that point, you really must start to think about increased ICP. And if you're thinking about increased ICP, you need to rule out this is not a hydrocephalus, especially an obstructive hydrocephalus picture. Anyone who has papilledema, again, it's not so much that papilledema is in and of itself a contraindication for an LP. And again, people with IIH get LPs all the time, but it's like, hey, there is something undiagnosed that's causing mass effect, and it may have been there for a while, and you really need to make sure that that's not an obstructive mass. And so, immunocompromised, age greater than 60, and any sort of depressed level of consciousness. Again, really important to get imaging. That's going to end up being a lot of patients, and so I think in most cases, these patients are ending up with a head CT before they get a lumbar puncture. The thing that I always tell people when you are about to do this lumbar puncture, it is critical in this situation that you do not forget to measure the opening pressure, right? We've all been there. You did an LP and like you were trying to get fluid and blah, blah, blah. And then all of a sudden you walk out of the room and you did not get the opening pressure. That is not this patient. Like this patient, you really, really, want to get lots of CSF. Once you've proven that there is no midline shift, that there is no obstructive hydrocephalus, there's no fourth ventricular mass. If you're feeling like it's safe to do a lumbar puncture, make sure you get enough of the CSF so that you can send it for all the studies that you are probably going to want to send for. And then please measure the opening pressure. I think one of the things that is the most devastating is that patients with meningitis can develop increased ICP. And that increased ICP can be a result of sort of this communicating hydrocephalus where they get, their arachnoid granulations almost gunked up with the purulent stuff and the inflammation. And therefore, they have this high ICP and herniate. And so I think in a lot of cases, we're doing a disservice by not putting in a CSF diversion. And I think that conversation is really helped when you can say to your neurosurgical colleagues, like, hey, we did an opening pressure and like the CSF just shot over the top of the manometer. I'm really worried this patient is sleepy and they need definitive CSF diversion while we are, giving them antibiotics, giving them steroids. Once you've done that LP, really you're looking at culture data, you're looking at cell counts, and then if you have access to one of the rapid PCR detections, a brand name like BioFire, those can be really extremely helpful because again, that's not going to be affected at all if you need to get antibiotics on board before you do a lumbar puncture. Imaging in this case, with the CT, probably most patients are going to have that. Imaging with MRI, I tend to defer that until after we have the lumbar puncture. I try to, make sure that we are getting the data that's going to direct our antibiotic therapy before we're kind of putting the patient through an MRI. It's, going to show you helpful stuff, but I'm not sure it changes management in the way that the CSF does. So a big, worry of all of ours is when we are working these patients up, this is not something we want to like drag our feet with treating. So Salia, walk us through sort of how do we approach the antibiotic choices and especially in the difficult situations where patients have allergies to the most commonly used antibiotics.
Sure. Yes, I kind of wanted to highlight what you said, Casey, about the patient. I think knowing about the patient's history can really help you a lot with what are the risk factors, what are you trying to cover, what antimicrobial should you use to actually cover the bugs that you're trying to cover. Before we get to the antimicrobials, a few things also about the LP and all that. I know that everyone wants to get that best LP that you talked about and champagne and LP and all that. The rule of thumb is, though, if you are highly suspicious that someone has meningitis, I know it's best to get the LP and then start antibiotics, but really we don't want to delay antibiotics if the suspicion is really high, because if you're just trying to like do your best and get the best LP, it may be hours and hours. So again, kind of risk versus benefit. If this is high on our differential list, I think everyone would agree that you just have to start treatment and then really not worry about that, because this, just like sepsis, every hour of delay could be devastating. As we talked about, this is a very devastating disease state. Now, as far as how to treat these patients, going back to the patient's risk factors, I think typically what I do and how I categorize these patients is community-acquired meningitis versus hospital-acquired meningitis. And then when you think about community-acquired meningitis, also you have to think about the risk factors with the patient, right? Is this like a 20-year-old previously healthy football player who came from like summer camp and now they have meningitis? His treatment obviously is very different from, a 75-year-old who came from home, also community, but they have very different kind of risk stratification. So if someone has no risk factors, right, the most simple, I think, case of meningitis you can get is football player that comes. The rule of thumb is really to cover for community-acquired bugs, and that's usually strep pneumoniae, Haemophilus, Neisseria meningitidis, as the name suggests. And for that, typically we do ceftriaxone and vancomycin. I kind of wanted to clarify here that we're not giving vancomycin for MRSA. We're giving vancomycin for resistant strep pneumonia. I have to highlight this because I can't tell you how many times people come to me and say, oh, the MRSA swab is negative. Can I just not do vanc? And I'm
No.
like, oh, no, no, this is a different indication. Let's keep it until we know we're not dealing with a resistant strep pneumo. And that's a big thing. I'm very steward. If I say that we have to keep the vanc, we really have to keep it. And, we target for high troughs, 15 to 20 is a trough for vancomycin that we're shooting for and all of that. If now you have that 75-year-old who comes from a community, guess what? Anyone over 50 or less than 2 years of age, we have to think about, in addition to everything that we talked about, we have to think about Listeria meningitis, and then we add ampicillin to that combo or combination. It gets a little bit obviously tricky if penicillin allergy is a problem or ceftriaxone allergy is a problem. My biggest piece of advice is that please investigate to make sure that is really a true reaction. If they received Ancef, 2 days ago, that's not a real reaction. But if you know for sure that they have anaphylaxis or something is described in the note that makes you really uncomfortable and you really want to treat them. So the way the guidelines really talk about is that for ceftriaxone, which is really intended to treat the strep and community bugs, usually moxifloxacin is the agent of choice that is listed in the IDSA guidelines, and that should be pretty, hopefully most patients can tolerate that. But if ampicillin is a problem, meaning that, you want to cover for listeria, and that's the problem, Bactrim is an alternative in that setting that the patient has a penicillin allergy. The next question that I usually have to kind of deal with is, what about dexamethasone? When do we actually think about giving dexamethasone? The literature behind us, to be very honest, isn't that convincing, but there are studies looking at efficacy of dexamethasone in strep pneumo infections in adult patients. This is really, the focus of this talk is really in adults, so I'm going to focus on the adult dosing and all of that. So really, the only convincing evidence is for strep pneumo that we typically use dexamethasone. And, as you can imagine, this is really only for community-acquired meningitis, and the dosing is 0.15 mg per kg every 6 hours for 2 to 4 days. And really, the guidelines don't want you to continue the dexamethasone unless you have strep pneumobacteremia or your CSF is growing gram-positive diphthococci or anything really that is giving you a huge kind of red flag about strep pneumo. So really, that's when we add dexamethasone. I have to be honest, in our hospital, it's rare for us to give dexamethasone. It's rare to know what the patient really has. It's rare to say that it's definitely community-acquired and it's definitely strep pneumo. But the idea is that if you want to do it, you have to give it 10 to 20 minutes before you start your antibiotics. And the idea is that you're really trying to inhibit or minimize this profound inflammatory response that you're going to get when you give the antibiotics, because it's going to kill the bacteria and all that. So give it before the antibiotics, and really give it before or when you think that you are dealing with strep pneumo community-acquired meningitis. So I would say those are really the highlights or the clinical pearls for community-acquired meningitis. Obviously, the story is a little bit different when we talk about post-op patients or people who just got an EVD or they were operated on.
Right. So I think of those patients, and I think of that being such a different risk factor group. And unfortunately, in our setting, I mean, I think that we probably see more of those patients than we do of the patients who come in off the streets with a new diagnosis of bacterial meningitis. And so walk us through kind of what are the other bugs that we need to consider and cover for if the patients had recent skull-based intervention, like a TSA, or they have a basilar skull fracture where there is something that is disrupting the skull base that would make them at higher risk of having maybe atypical pathogens.
Yeah, absolutely. I think I'm going to start with like the extreme cases, and then what are the cases that are maybe not as extreme. I think when you have someone with with an EVD, or clipping or very deep kind of manipulations, and then a few days later they're febrile, they're very altered. Their initial kind of neurological injury is not really explaining what's happening to them now. I think that is a perfect population to think about, okay, this could be nosocomial. And then for that, we're really thinking about really big and difficult bugs. And those are, Pseudomonas comes to mind. MRSA is here now that comes to mind. Acinetobacter, other kind of gram negatives, Enterobacter, things like that. These are the patients that should be proactively treated with vancomycin, and cefepime is typically the agent of choice. Now, if you have a patient with maybe prior cefepime exposure, or they have had some resistance, obviously that's the time to think about maybe even broader antibiotics such as meropenem. Remember that if you have someone in valproate, you have to get the valproate off because of the drug-drug interactions that we talked about in our status
Such a pearl.
talk.
Such a pearl.
Just a pearl. So a couple of things, and honestly, even in that case, I think your CSF analysis should give you a lot of good information of, what is happening. Then, thinking about other kind of nosocomial infections, if someone comes in, with, let's say, just skull-based endonasal neurosurgical procedure, and we're just suspicious that maybe this is not deep, this is not penetrating, or there's a fracture, I think in those cases, you're probably still thinking about, your strep infections, your Haemophilus, strep that we talked about. And I think ceftriaxone should be probably enough. Obviously, if you are concerned that because of your patient's risk factors, you have to be broader, that's always a very good idea to actually have them broad and then narrow them if you've ruled out all the other causes or you have culture data to support your clinical suspicion. Another clinical pearl here, because I see that a lot, ceftriaxone dosing for meningitis is not 1 gram daily. It is 2 grams Q12, just making sure, because this happens all the time. You may get patients from the ED, that's the UTI dosing. It's just fascinating that how little pearls or little details like that could be really life-saving. So just making sure that, again, everything that you're using, all the medications are really dosed for CNS penetration, and usually there are higher doses. Now, obviously, if you have someone with a true penicillin allergy, if you have investigated that they have, yes, anaphylaxis, or you have had significant hives and you're really concerned about that, you have to obviously think about an alternative for your cefepime. And that's a really difficult conversation. At least I can tell you in our unit, the options are, or any, I should say, unit, the options are aztreonam and ciprofloxacin. But the problem in our institution is that we have a very high rate of resistance for Cipro because a lot of people come in with quinolone exposure in the community. So these are just some of the conversations to have with the ID specialist to kind of figure out, can you desensitize these patients if you have to, just because Cipro or aztreonam may not really be the best option for them if they're very sick and you need a very good anti-pseudomonal antibiotic.
Yeah. Celia, what about Zosyn? Can I use Zosyn?
Unfortunately, you cannot because of lack of good penetration into the CNS or into the brain. The real idea is that, piperacillin tazobactam is really the tazobactam component, which makes Zosyn great, doesn't get into the brain that much. So unfortunately, you cannot. But, if you have someone who has a different infection, you're probably, you can cover, gram negatives with that agent, except for meningitis, which is our topic today. But unfortunately, this antibiotic is out, and that's why we're not talking about it.
Right. I think that is a really important pearl because I think oftentimes critical care, uses Zosyn quite a lot. And it's just really important for any provider out there to recognize that that's a great drug, but it is not going to get you good CNS penetration. And so if you're really worried about meningitis, this is not the drug for that. Cool. All right, let's move along a little bit and start to think about encephalitis and just sort of the definition. Again, encephalitis can have multiple different etiologies. We're going to focus on infections. But again, just like for meningitis, you can have autoimmune, you can have para-infectious, you can have malignant. There's a very broad differential. But when we think about encephalitis that's caused by infectious etiologies, we're really looking a lot at sort of the HSV, VZV, West Nile virus as being some of the most common etiologies for patients to have sort of viral encephalitis. And of that, I think HSV is probably one of the most common of this sort of rare conditions. And I think it's important for us to recognize that because it is a treatable cause. And for a lot of these other etiologies, the treatment may not be as efficacious, whereas HSV, we have really good data that acyclovir can treat. We also have to think about, other sort of infectious bacterial infections and then toxoplasmosis. So I think toxoplasmosis is, again, really important for us to clue in, especially for our immunocompromised patient population. When we think about sort of bacterial causes of encephalitis, really what we're actually kind of moving more towards is what are often brain abscesses, right? So when bacteria tends to take over brain parenchyma, it's not so much that it's causing global inflammation. It tends to cause an actual nidus of infection that then becomes walled off. I just want to clue in on, or just mention this term cerebritis, which gets thrown around. I don't love that term because it's not really well defined as an etiology. It is, at best, I can say that it's sort of this like stage before an abscess where there's some purulent discharge, but it's not encapsulated. It can be in multiple brain spaces, so it could be both sort of within the parenchyma And then also sort of within the subarachnoid space, and then maybe in the meninges. And so it's not really localized infection, and it's not walled off. And so it's sort of this like collection of bacteria before it becomes an abscess. But I shy away from that term because I don't think it's universally agreed on what that actually is. Um, so when we're thinking about HSV, and then, or let's say when we're thinking about encephalitis, there are some that can be diagnosed from the LP, which, like HSV is a prime example. You can get a PCR test. If it's negative and you have a very high suspicion, this is one of those where you may have to wait and LP the patient again and then get the positive result. That's actually pretty rare that that happens, but it is reported. And so I always kind of keep that in mind for patients who are really presenting with, a limbic encephalitis and probable seizures and evidence of inflammation in the temporal lobes. If that HSV PCR is negative and it's early in the case, I'm going to keep treating them and then do another LP in a couple days. Um, so we have some cases where the LP can diagnose encephalitis. But I think it's really important to focus or to acknowledge that once an infection like a bacterial abscess becomes walled off, that LP is not going to be very sensitive for diagnosing a bacterial abscess. And so, unfortunately, the only time where that might be positive is if the abscess has ruptured into the ventricular system. And that's really usually a very serious consequence. That patient is going to be extremely ill. And fortunately, that doesn't happen all that often. So, when we think about our bacterial infections that have walled off, we're often left at needing sort of surgical biopsy or removal of the abscess to get a true pathogen confirmation. So Zalia, when we think about encephalitis, we've talked a lot about, HSV. How do you do the medical management of this?
Yeah, as you said, Casey, I think this is where it gets a little bit uncomfortable and complicated because sometimes you really don't know what you're treating and you may not have all the information right away. I think HSV is probably the one that is the easiest. Just like you said, I think you either have the PCR that is positive or the PCR that is negative, and with the other information from your CSF analysis, you're like, you know what, this is not even viral. I had the acyclovir, and again, the dosing is 10 mg per kg, IV Q8. It's not oral. It's not 5 mg per kg. Again, like you do have to dose adjust in renal failure, but in a normal renal function, we really want to give the CNS dosing of 10 mg per kg. IV every 8 hours. Just remember also that you have to use the adjusted body weight. You have to hydrate patients. The risk of nephrotoxicity is pretty high. So it's a pretty tricky drug, but if you dose it correctly and if you do all the precautions, hopefully, it's done safely and it's efficacious. Now, if just like you said, if the suspicion is high and the PCR is negative, it has happened for us also that we've repeated, the PCR and it came back positive, and we're happy that we kept everything on and we didn't give up. Especially, if the clinical or MRI, finding was very suspicious. Now, on the flip side, I think it's important to note that HSV in an immunocompetent patient without encephalitis does not need treatment. So if you just have someone that is like not altered and they don't have encephalitis and they just have HSV PCR positive, that doesn't necessarily mean that you have to treat them. VZV is another, I think, viral encephalitis infectious cause that we see from time to time, and you could use acyclovir for that. And I think that's one of the encephalitis kind of indications that, especially if you see vasculitis, you could consider corticosteroids, and that's when we talk with neurology folks, and they're very helpful with that management. Toxo is very kind of, I think, interesting. We see that definitely in immunocompromised patients, especially, HIV patients with really low CD4 counts. I highly recommend that ID is involved in those cases just because they need longer duration. But just the broad clinical pearl is that they do need the agent of choice is permethazine plus lipodiazine plus leucovorin. And really these patients, you definitely need ID and your clinical pharmacist to be involved. They need up to 6 weeks of treatment, even longer, depending on what's happening with them. West Nile, supportive care. I know that we actually had a case of HHV6, and that was mostly supportive care, and ID was very involved in that. If you have tick-borne infections that you're worried about, obviously doxycycline is something to consider, especially if that's high on your list. Duration of therapy really depends on what you're treating. As we talked about, toxoplasma can be very long, but then, with HSV, depending on the significance of the disease, could be anything from 10 days really to 21 days, depending on how sick the patient is. So that's just something to keep in mind. But I think it's very variable when you have these, kind of not very typical infections that you really need to think about your patient's progress and how they're doing.
Yeah, absolutely. I think doxycycline is just really an unsung, like it is an unsung hero. Like what can't doxycycline do? The other thing question becomes with these patients is, who, if they have a bacterial or a assumed bacterial abscess, when are we going to intervene to remove the abscess versus just supportive care with medical treatment? And unfortunately, when it gets to the point where it's a walled off infection, medical therapy is likely to be ineffective. And so I think, the times where we're thinking about maybe getting by with medical therapy is very small abscesses, less than 2.5 centimeters, multiple, where it seems like it's hematologist spread. And so we're treating for, the endocarditis for a very long time anyways. But normally, especially in these larger cases with the sort of literature cutoff being that 2.5 centimeters, we really are thinking about, surgical debridement and source control. And that also serves as, the way to identify what actually the pathogen is. And unfortunately, a lot of these are polymicrobial. And sometimes, it is just unfortunate that the reality is that these patients need to be on multiple antibiotics for a very long duration. Um, you know, Again, you have to balance that risk with, where is it located and how much eloquent brain tissue would be injured with the surgery. And so this really is a multidisciplinary conversation between ID, neurosurgery, and the neurocritical care team, and with pharmacy on board about the, duration of antibiotics that might be needed and the risk factors of long-term antibiotics. Um, these can be really interesting cases, and often are very complex. And I think that's sort of one of the things that makes, the treatment of both meningitis and encephalitis really interesting. So, Salia, wrapping up, anything, final pearls to leave us with?
I think we covered most of, the infections. One thing I wanted to kind of mention, we didn't really spend a lot of time about fungal, meningitis. It's obviously very complicated, again, in immunocompromised patients. I think it's fair to know that if you're starting something for fungal infections, it's very reasonable to start very broad with something like amphotericin. Again, CNS dosing, usually 5 mg per kg of the liposomal formulation, because the risk of nephrotoxicity is really lower. And then the other thing we didn't really talk about as much as the CMV encephalitis, that, that also could be very complex as far as, what other risk factors the patient may have. And that's when we think about ganciclovir, or sometimes even combining ganciclovir with foscarnet, if they have a resistant kind of strain of CMV, which you really have to watch out their kidney function and all the things. But it's obviously impossible to talk about all the infections, but those were the two that I really wanted to kind of highlight quickly before we wrapped up.
And just a reminder to the listeners, like, this was a great chapter, and there are so many nice tables within it of sort of common etiologies, your initial treatment strategy, what you would narrow to, and trying to think about sort of risk benefit decisions in terms of things like the surgical management in patients with bacterial abscesses. So really want to emphasize, go and check out the chapter, but this was a lot of fun and it was great to be back.